Now let us move on to the operative obstetrics related to vaginal delivery, that is assisted vaginal delivery. That is, some form of assistance is provided for vaginal delivery which could not happen normally because of some or the other reason. So assisted vaginal delivery of cephalic presentation involves the use of either forceps or vacuum to achieve delivery of the fetal head. So these instruments allow the operator to apply extraction forces along the pelvic curve. So in vacuum it is application of suction and traction on the fetal scalp, while in the forceps cradle the parietal and malleolar bones of the fetal skull. In addition to applying traction laterally, they displace the maternal tissue. When we are dealing with the operative vaginal delivery, there is a classification, it's the ACOG classification 2000, which depends upon the level of the station of the head. And depending upon that, it can be divided into mid, low, or outlet. Earlier days, it used to be high level also, but now that has been abandoned. So mid means when the leading point of the skull is above station, that is plus 2 centimeters. That is, it is at 0 to above plus 1, but not above the ischial spine. So it is between the ischial spine and above plus 2 station. Low means when the leading point of the skull is at more than 2 centimeters but has not reached the pelvic floor. Outlet is when the fetal scalp visible without separating the labia and the skull has reached the level of the pelvic floor. Sagittal suture is in direct anteroposterior diameter or in the right or left occipital anterior or posterior position. Fetal head is at or on the perineum and rotation of the fetal head is less than 45 degrees. So in the mid forceps, when you are doing per abdominal examination, fetal head less than 1/5 of palpable per abdomen and leading point of the skull is above the station. So you have to combine both the abdominal palpation as well as the vaginal palpation, as a vaginal examination, to ascertain the exact position of the fetal head. So in this diagram we can see this is the 0 station, this is the minus 1, 2, 3, 5 and here is plus. So above this level is the mid and from here plus 2 to it becomes the low, and if it is at the perineum then it becomes an outlet. So indications for operative vaginal delivery are almost similar for both forceps and vacuum. The maternal indication includes certain medical disorders like cerebrovascular disease, hypertensive disorders, cardiac disease, where the second stage of the labor should be curtailed. So then if there are inadequate expulsive maternal forces, maternal fatigue and exhaustion, and among the fetal indications are non-reassuring fetal heart rate, fetal distress, and in the after coming head of the breech, if it doesn't come, then suspicion of fetal compromise. Other indications include prolonged second stage of labor, that means more than 2 hours in nulliparous and more than 1 hour in multipara, and to cut short second stage of labor due to some reason. So whenever the surgery is done, like operative obstetrics is done, you have to take an informed consent. But in these cases, a genuinely informed consent will be difficult because it's a stressful situation surrounding the second stage of labor. The options at this stage generally include either waiting, assisted vaginal delivery or cesarean section, and these should be discussed with the woman and her partner to go forward. So whether cesarean is better or assisted vaginal delivery is better, or one can wait for some time more for the spontaneous delivery to occur on its own. So analgesia in these cases, if the assistance required is in the low or outlet portion of the pelvis, infiltration of the perineum with local anesthesia may be all that is required. At the most, pudendal block can be given. So in general, more analgesia is required for forceps than for vacuum assisted deliveries. So there are certain prerequisites for operative vaginal delivery. They are almost similar in both vacuum and forceps. The fetal and maternal criteria, prerequisites for application of either vacuum or forceps, include that the fetal head should be engaged. That means our abdominal palpation should be less than 1/5 palpable. Cervix must be fully dilated in most of the cases. Membranes must be ruptured. Fetal head position must be known, whether it is left occipital anterior or right occipital anterior or in transverse position. And pelvis should be adequate. Bladder and bowel should be empty. There should be adequate maternal analgesia. And of course, informed consent, verbal or written, with prior clear explanation is mandatory. So other prerequisites include an experienced operator, aseptic techniques to be used, backup plan and facilities in case of failure, presence of neonatologist, and willingness to abandon when difficulties encountered. So assessment for assisted vaginal delivery. One should perform combined abdominal and vaginal examination, as I told earlier, to accurately establish the level of the descent, whether it's a mid-level, lower or low, or outlet. The sinciput and occiput should be carefully palpated. It's a good working rule that never to apply forceps if the sinciput can still be felt per abdomen. So then one should go directly for the cesarean section if the labor is prolonged. In addition to accurately determining the level of the descent of the fetal head, position and attitude of the fetal head, whether flexed or deflexed, are very important. So the position can be ascertained by identifying the sagittal suture and anterior and posterior fontanelle. So trial for assisted vaginal delivery, it entails moving the woman to the operating theatre so that either an assisted vaginal delivery or a cesarean section can be undertaken. This is explained to the woman and her family members and OT staff prior to the procedure. They are told that if the forceps or vacuum delivery proceeds smoothly, then the vaginal delivery will be accomplished smoothly. Otherwise, one has to take up her up for cesarean section. So if there are difficulties, of course, the attempt will not be sustained and cesarean section is the only answer. So now coming to the vacuum extraction of ventouse. This entails traction of the fetal head by creating negative pressure through a cup which is supplied on the head of the fetus. So there are the various components of ventouse. The main component is a specially designed cup with a diameter of 3, 4, 5 or 6 centimeters. Rubber tube attaching the cup to a glass bottle with a screw in between to release the negative pressure. Manometer fitted in the mouth of the glass bottle to declare negative pressure. And another rubber tube containing the bottle to a suction piece which may be manual or electronic, creating a negative pressure that should not exceed 0.8 kg per square centimeter. So this is the setup, which is this is the vacuum bottle, this is the cup, then the knob plate, the chain which goes in the rubber tubing, and then the screw cap for tightening and releasing the negative pressure. And this is the chain which goes in the rubber tube, and vacuum bottle, manometer over here, there's a valve over here, and then the suction creation which can be either manual or electronic. So the main difference between the vacuum extraction lies in the type of the cup which is being used. In the olden days, and even now, the Malmstrom cup was used. It's a metal cup to its center attached to a metal chain passed through a rubber tube. The other end of the tube, that is the chain, is attached to a handle for traction. So the bird's cup is almost the same as this, but here the suction rubber tube is attached to the periphery of the cup, while the handle of the traction is attached by a separate metal chain to the center of the cup. This is at the periphery and this is at the center. And the recent ones are the soft cup. It's a bell-shaped, this thing's with 6.5 centimeter diameter. Other diameters are also available. A soft celastic cup which is made of firm but supple celastic material. So this is tougher, and this is like softer for the fetal head also. So principles of use of the vacuum cup. First, one should identify the flexion point on the fetal scalp. So this flexion point is situated 3 centimeters in front of the posterior fontanelle. This is the posterior fontanelle, 3 centimeter. In front of that is the flexion point. So if traction is directed from this point, the fetal head has got a maximum flexion, and the minimum diameter, fetal diameter, will pass through the birth canal. So then the delivery will be easier if the cup is applied at the proper point. So as mentioned in the indications include, we have already mentioned the assisted vaginal delivery. So most of the indications are the same. However, this vacuum is not recommended in preterm babies and not used for the aftercoming head of the breech. So during the first stage, though in most of the cases the cervix should be fully dilated, but in some circumstances the vacuum can be applied even in the not fully dilated cervix. So if the second stage is approaching and the patient is still in the first stage, the small cup, that is 3 or 4 centimeter cup, may be applied in the soft stretchable cervix of not more than 7 centimeter dilatation. So if it is fully dilated, then the bigger cup is applied. The vacuum cup also can be used during cesarean section to extract the fetal head through the uterine incision. So vacuum cup, one is the function of this vacuum cup is traction, but we don't rotate the fetal head with the vacuum. However, when the fetal head descends, it rotates spontaneously when it meets the pelvic floor. So one should not try to rotate the head with the cup, because if that is done, then the cup will slip. So what are the contraindications for vacuum delivery? Moderate to severe cephalopelvic disproportion, presentation other than vertex, premature babies like less than 34 weeks, chance of scalp avulsion or subepineuritic hemorrhage, suspected fetal coagulation disorders, and intact membranes. So procedure: patient is placed in the lithotomy position, antiseptic measure for the vagina, vulva and perineum are done, and vaginal examination is mandatory to check the pelvic capacity, cervical dilatation, presentation, position, station, and degree of flexion, that is attitude of the head, and that whether the membranes are ruptured or not. So pudendal block or perineal infiltration with 1% lignocase is usually sufficient. And in multiparous women, especially when the head is quite low, the vacuum may be applied even without anesthesia. Before the procedure, the instrument should be properly assembled and the vacuum is tested prior to its application. Otherwise, sometimes what happens is, if you're not properly prepared, the vacuum section is not created properly and the cup may slip. So application of the cup, the largest cup at that dilatation which can be easily passed, is introduced sideways into the vagina by pressing it backwards against the perineum, and then applied as near as possible to the posterior fontanelle over the flexion point, and this position will promote flexion of the head and bring the smallest diameter of the fetal skull into the maternal passage. And one should be sure, once the negative pressure is being created, that there is no cervical or vaginal tissue, nor the umbilical cord or a limb in complex presentation is included in the cup. Otherwise, there will be a lot of damage. So this figure shows the other type of when this thing can be applied, vacuum cup. Here it is the median and flexion flexion point, and this is the paramedian at flexion point. This is the median at deflection point, and this is the paramedium at deflection point. So if it is applied, then the head, instead of being flexed, it gets deflexed. So another important thing is creating the proper negative pressure. Once the cup is put over there, holding the cup in place, the negative pressure is gradually increased by 0.2 kg per square centimeter every 1 minute until the 0.8 kilogram per centimeter square is attained. This creates an artificial caput within the cup, which is known as chignon, and traction on the handle is made perpendicular to the cup and intermittently during uterine contraction. The direction of the pull is changing as the head descends through the birth canal. So this thing, after application, the second step is of course the traction, and traction must be at the right angle to the cup, like this demonstrated over here, and this one is the wrong. This is not at the right angle to the cup. So principles during traction is the traction should be synchronous with the uterine contraction, and direction of the pull should follow the curve of Caros, and traction should be at the right angle to the cup, as demonstrated over here. And so the curve is following the curve of Caros over here. So this is following the curve of Caros, and the head delivers over here. So once this head is delivered, then the cup is released. It's reduced slowly as it was created by opening the screw release valve, as this diminishes the risk of scalp damage, and the cup is then detached. If it is not released this thing properly, then there can be damage to the fetal scalp. So this is the application of the cup. When the suction is created, this gets swollen over here and the chignon is created. So you can see over here when we are pulling it out, and once the vacuum cup is released, then this swelling is appears like this thing. She can be confused with cephalometoma sometimes, and caput succedaneum also. So this is specialty of the thing. So the diameter is like that of the cup diameter. So what are the birth safety rules for vacuum extraction? The head must be completely or partially delivered with no more than 3 pulls along with the uterine contraction. The head is at least begin to move with the first pull, and then cup must not be applied more than twice. Then the procedure should be abundant. Application of the cup must not exceed 20 minutes. So these precautions one should take. And what are the complications? One is a superficial skin abrasion. There can be sloughing of the scalp, cephalometoma. Then the subepineuritic or subgaleal hemorrhage, not limited to suture line, then it is not subperiosteal. Intracranial hemorrhage over here, retinal hemorrhage, and because of the constant pull and some hemorrhage, there can be jaundice, neonatal jaundice.